Tonight's session is really about the cancer services at National Referral Hospital, NRH, in the Solomon Islands, and we're privileged to have quite a comprehensive panel tonight. Tonight's session will run more or less like a Q&A session. Unfortunately, today the National Referral Hospital, NRH, has gone into lockdown due to COVID outbreak in the country, but also at NRH. And unfortunately, two of our key panellists, Dr. Leanne Panissi, who's the Director of Gynecological Services in the Solomon Islands, and Dr. Rooney Jaggally, the Director of Surgical Services and previous Medical Superintendent at NRH, could not make it as they had to attend a COVID lockdown crisis briefing. My question for Dr. Rooney Jaggally was to comment on the current impediments to cancer care delivery at National Referral Hospital, and he has provided me with this pre-recorded response.
Gary asked me to comment on some impediments to cancer surgery at the National Referral Hospital. So 5 minutes is too short a time, so I'm just going to mention a list very quickly, not in any particular order of importance. I think the first one is just operating time. We just do not have, enough theatre time to do cancer surgery, which can take a while. So the solution to this is to build more theatres, proper operating rooms for us. The next one which I have on my list is surgical expertise. There are a lot of other cancers that we basically do not have the expertise locally, liver cancer, CNS cancers, etc. On the other areas, head and neck, breast, which bowels, which we do, but of course still we also would like to, there's a lot of room for improvement as well, and this requires specific training, attachments, workshops, mentoring, etc. There is also a lack of post-op support. We do not have a high dependency or ICU, no ability to ventilate post-operatively. We could improve on post-op pain control. There is very inadequate physio in rehabilitation areas. There is no parental nutrition support at all. So these areas need improvement, basically. The lack of supportive treatment modalities, there's no point in doing surgery, but if you don't have other treatment modalities, particularly radiotherapy, chemotherapy, thanks to Dr. Soma, who's taken up chemotherapy and oncology, and the support that we have from our colleagues in Australia. So these are areas that need more investment. In the area of chemotherapy, if we have easy referral pathways to other places, even if it's Fiji, PNG, or Australia, that will be something that will be very good.
The video ended here. Other impediments that Rooney wanted to mention include lack of diagnostic support, so CT, PET-CT, histopathology, basic tests, blood availability, and finally late presentation, so patients presenting with big tumours too big to operate on, lack of education, patients deciding to have traditional medicine, and finally the need for more tours to the provinces for screening. We'll now move on to the other panellists who were able to turn up to tonight's session. Professor Desmond Yip, who is the ANU professor in Canberra. He's also the head of Department of Medical Oncology at Canberra Hospital and has been integral in establishing a medical oncology unit with Medical Oncology Registrar Andrew Soma, who he has taken really on as a mentor. And we'd like to know what progress you've made with the medical oncology unit at National Referral Hospital and what we can anticipate from this facility maybe in the next couple of years.
Sure. I did give some background. Our main work with the Solomon Islands is to build capacity and capability and to build a sustainable service rather than us going there and providing a service. So we've been involved in helping them set up the infrastructure and also training staff and making sure they've got some backup so that the service can still run if people go on leave or move on. So we did this initially in 2015 when Rooney asked us to scope the cancer services and to help them set up an oncology unit. So what we've done is basically worked with the local health authority there. The Med Super at that time was Rooney Jagili, and we basically did what they wanted, right? So I think the way it approaches is to see what their needs are, and rather than us saying you should do this. So basically, each time they've come to us with a request, we've gone and tried to fulfill that request and done needs analysis with them from their point of view, rather than coming in as outsiders and saying, this is how you should do things, what you need there. So he came to us to scope the cancer services. Then subsequently, he went to DFAT and asked for a mission in-country visit to help with training and stuff. And so their unit was actually commissioned in 2018. And they had a purpose-built, building. It was repurposed from being a midwifery school to become their standalone oncology unit. And DAISI actually helped us to ship over some chemotherapy chairs that were from a decommissioned unit in the private hospital in Canberra. We took over some infusion pumps, and we revised their chemotherapy protocols, which were quite old and based from Fijian or Papua New Guinean protocols, and brought them up to date. They asked for some of their staff to come over to Canberra. And so we brought over Andrew Soma from Survivorship to get him trained up. And we brought over 2 of their oncology nurses at the end of 2019, also to do some training. They had an in-country pharmacist, an AVI pharmacist who was there before our first visit with DFAT. And we've had a succession of other people who've been over there, and including a Australian-trained Solomon Islands pharmacist who trained at Monash, who's still working in the unit. So we've got a number of pharmacists who can, prepare cytotoxic chemotherapy quite safely. And we've taught them about use of PPE. We can do a lot of the intravenous chemotherapy protocols. So we can treat for curative intent, lymphomas, testicular cancers. We can give adjuvant therapy for breast cancer, as well as colorectal cancer. We can give palliative chemotherapy and downstaging chemotherapy for patients with colorectal cancer, as well as head and neck cancers. We can downstage them for surgery. We can give treatments for lung cancer as well. The gestational trophoblastic cancers we can treat for cure. So there's a number of treatments that we can give over there with a range of chemotherapy drugs. So we've helped them get new cheap drugs onto their formulary so it can treat a wider range of tumor types. So part of the problem, I guess, at the moment is their capacity, because they've only got 2 dedicated nurses, so they've got maybe another 3 nurses who are trained up to backfill. We've got Andrew Soma, who's a registrar in oncology. To get his qualifications, he has to complete a master's degree through the University of Canberra, which is by distant training, but his clinical work is actually very demanding on him. So the hospital did provide some back cover with another registrar, but apparently that registrar had to be taken to help with COVID vaccinations during the pandemic last year. So it's been rather difficult for him to work full-time as well as do this master's degree to get his specialist qualifications. The infusion pumps that we brought over have failed now. That was second-hand ones. And so they're having to use normal drip sets, which is not very efficient to give chemotherapy. They had a cytotoxic chemotherapy isolator. So it's like a laminar flow hood or isolation unit to make up chemotherapy drugs. That was delivered pre-pandemic, but again, they got the same issue of trying to get staff from overseas to actually get it up and running. And that would improve their ability to produce their cytotoxics in a safe manner once that gets up and going in the next few years. And their CT scanner, which I think Ian will talk about later on, is due to be commissioned. That would help a lot in the staging and assessment of responses in patients with cancers. But we would have to get them used to how to incorporate that modality into their treatment of patients.
Yeah, thanks, Desmond. That's a very comprehensive answer to the question. I must admit, I'm pretty impressed. You've certainly gone about things in the right order, doing a scoping session in 2015, seeking out their advice, and what you've been able to achieve since 2018 is pretty amazing. We might move on to Rooney can't make it. And I should add that National Referral Hospital is currently in lockdown due to COVID from today until Saturday this week. It's quite a disaster. There's staff, half of the medical staff are COVID infected. So, and staff, even without COVID, staffing issues are always a big concern, and continuity of care. I think you've got it right, Desmond, in training up Andrew Somer as a registrar so that you do have that continuity of care. And hopefully we can keep him in the Solomon Islands and avoid, the brain drain which tends to occur. So for Mike, can you hear me? Mike Boohan's a general surgeon in Gizo Hospital. Gizo is a provincial hospital. It's an amazing hospital built by the Japanese. It's got very good facilities, but it is still a provincial hospital. It's quite remote in the Western Province. So Mike did his training at Port Moresby, his master's in surgery. He's been working now just over a year, I believe. Is that right, Mike, as a general surgeon in Solomon Islands?
Yeah, going up to 2 years. 2 years.
Yep. So I guess you've been for the last year, I think, in Gizo Hospital, and I'd like to get your perspective on what cancer cases do you think are suitable for Gizo Hospital, what cases we should be referring to the National Referral Hospital, and maybe even which cases should be referred out internationally, just to get your perspective of things from a provincial hospital surgeon's point of view.
Yeah, thanks. Yeah, so here in Gizo, fortunately this year I'm lucky to have just an anesthetic registrar who's joined me from Honiara. He's quite competent, so we have been able to do some cancer surgeries last year. I think the ones that we are within our limits here would be breast cancer, thyroid cancer, and skin cancers, and just soft tissue cancers. Those are the ones that we can safely do at the provincial level without an anesthetist, qualified anesthetist, just with a registrar with experience. So those are the ones that I have done last year, just breast cancers. Those who presented with solitary thyroid nodules. So we've been just doing a hemithyroidectomy, send the specimen up and to Brisbane, and if it comes back a thyroid cancer, then we book them down for total thyroid. But usually we've been just doing hemithyroidectomies. Those are the ones that I can safely do here. I think all the rest, anorectal tumors, colorectal tumors, advanced thyroid, and we will just send up to Honiara and see if they can be done up in Honiara.
And Michael, that's primarily due to the better anaesthetic services rather than your surgical ability, or is it a bit of both?
A bit of both, anything, because the registrar doesn't do kids as well, because of the it's not confident to do anesthetize smaller kids, so it's all kids with any tumors or anything benign or malignant tumors would have to be sent up to Honiara.
And do you have a visiting anaesthetist from time to time that allows you to do cases that require more intensive?
Yes, so pre-COVID, what I do is I would get the cases booked, book them up, and get the anesthetist in Honiara to come down, and we'll do a week list of cancer patients. And they would also train the anesthetist along the way. Actually, the anesthetist, my anesthetist would do most of the cases with their help, but just for safety and all these other aspects, I call in the anesthetist from Honiara, and we would do a week's list of breast and thyroid cancers mostly. So we've done last year. We have done a 3 weeks of surgeries, mostly cancer, but breast and thyroid.
Thanks for that. I mean, when you compare the infrastructure at Gizo Hospital with National Referral Hospital, they're actually fairly similar. Neither hospital has a high dependency unit, an intensive care unit, a blood bank. I guess your pathology reagents are not always quite as good as what they are in National Referral Hospital, but you're on a very similar par. You just don't have a group, you know, you're just there on your own with one anaesthetist. So hopefully with those repeated visits, you know, do you think there is a role for training you up to do the more difficult thyroid cancers at Gizo Hospital?
Yes, I'm just confident in doing straightforward solitary thyroid nodules, but those with cancers with multiple lymph nodes that need dissection, I don't touch them.
Okay, but perhaps if a visiting specialist such as Professor Carsten Palmer, who's going to talk later, were to visit Gizo, it might in fact be appropriate to do at Gizo, just like NRH, because your facilities are really very similar. But yeah, I guess it's got to do with your confidence levels, and that might take a few visits before you get the confidence up. So, Deborah, you're an anatomical pathologist from Brisbane, and I believe you've been involved in the reporting of histopathology, which I think from PNG and the Solomon Islands comes to you for workup and reporting. Is that right?
Yes, sort of. I've just been working. I worked the last couple of months at the Royal Women's here, which gets pathology from National Referral Hospital in Solomons. I'm not sure about PNG. Okay. I didn't always recognise where stuff was coming from, to be honest. Okay. I did definitely recognise the names from the Solomons and the addresses. What I couldn't tell from that was how slow we were getting stuff turned around, which I know was the question. The Royal, when I was working there, was operating for our Australian specimens, was operating at 2 to 3 weeks behind. So even within Australia, specimens coming down, they drain everything from Queensland, every little hospital that doesn't have a pathologist. So Bundaberg and all our remote places also send their specimens in, and our turnaround time for them was 2 to 3 weeks. And I think, I don't know how the timeframes, you know, for the Solomons and places like that have been a couple of years ago, like if it's sort of ballooned out. But I think that the major time delay that I could see was actually getting the specimens shipped from A to B. So if you've got a specimen, if you've got, say, a breast coming off in Gizo, then that specimen goes to wherever they process it, gets sent down to their lab. And as I understand it, so in Honiara, the specimens get separated into what gets done in Honiara and what will come down to the Brisbane. And I think they sent most of the big ones down to Brisbane. So then they've got the next, you know, you've got to get organised there, then sent on again from Honiara to Brisbane. Then Brisbane itself has its 2 to 3 week delay before the specimens come out. So everything we did was old. And then on top of that, I have to admit that I think the problem when you're working is there's a bit of pressure to get stuff done for the meetings that you have in-house. So it's fair to say I think there's probably a slippage that occurs then because there's no pressure to get the Solomon's work done. You know, there's no one on your back. There's no one calling up about it. There's no meeting that you're going to get rung up about for it. So I think that means that it's probably not prioritized like, say, our gynae oncology in-houses gets prioritized because you get tapped on the knuckles if it's not out.
I think that's an interesting observation, Deborah. I think that might be somewhere where we could highlight or prioritise the work in the Solomon Islands by perhaps doing even a teleconference MDT type meeting.
I did wonder, if that would, because if you say to someone, look, I really need this meeting, I've got it at 4 o'clock this afternoon, it'll get done.
Well, that's just human nature, isn't it?
It's human nature, yeah. Then the other one is, I wasn't sure. So obviously in Queensland here, the reports go back electronically. So the minute I sign it, it goes across and it turns up on, it goes somewhere. I was never clear on how the reports went back to the Solomons, if they were going back electronically, by fax, presumably not by snail mail, because the thing is, there's not even the flights anymore because of COVID. There's not the same flight, and everything's slowed down.
Andrew says there's remote access from a terminal in pathology. They can access the Queensland pathology results electronically.
So it should, that should have been fast once we got it.
At the moment, I still think the regular Friday flight is still operational. It's for freight only, though.
But a specimen is, well, I don't know what the specimens go on. And I also don't know how much delay, like, I noticed personally when we were trying to get specimens from one hospital that came down to us to be reported, that like they have to move between hospitals in Brisbane. There's honestly a 24-hour delay every time someone touches it.
Right.
Just, it does your head in.
Well, just to give you some perspective, look, that's not too bad. I've spoken to Elvis Jafflet, a general surgeon from PNG, and a few other surgeons where they can wait up to 6 months for a pathology report to come back.
Yeah, that's really bad.
And the patient's oftentimes, not alive by that time. I've just done a remote locum to Roma Hospital where they said it can take 3 weeks. So I think the longest report I've heard from Leanne Panissi, who couldn't make it, she sends her apology, she's in isolation, is 3 to 6 weeks. So look, it's not a bad service, but I think you've highlighted a key area where we can perhaps prioritise the pathology reporting indirectly by having a telehealth conference, perhaps where we get a pathologist to present it, and that's always a good incentive. Nobody wants to look silly on camera or in a public meeting, and hopefully we can do that. That would be my desire at some point, is to sort of have a MDT that covers all cancers to speed up the reporting process.
I think the other thing I wondered about, like, there was quite a bit of discussion about what could be done in the Solomons, and I do wonder if there was a bit of education. Like, I'm quite surprised when I listen to all those those options for chemotherapy. If you know that there are people waiting who can be, where there is further treatment that can be offered, then that also, I think, maybe educating the pathologists as to what, sometimes people are casting around uncertain about sort of what it is there, in terms of what to do, how much to do, what stuff to do. But I think actually letting them know a bit more about where they're sending the reports to may also help. Because people want to do the right thing, but it's a very unknown factor.
Thank you, Deborah. I'm going to move on to Professor Carsten Palm, who's a professor of head and neck surgery. He's the head of the head and neck unit at the Royal Prince Alfred Hospital in Sydney, which I believe is the single largest head and neck unit in Australia. Carsten's given a number of talks on DAISI Zoom sessions on head and neck dissection. And the question I have really for you, Carsten, is, do you think that radical neck dissection or head and neck cancer surgery is possible or practical or even appropriate in the Solomon Islands at a hospital such as National Referral Hospital, which has no radiotherapy, no high dependency or intensive care unit?
Thanks, Gary, and thanks for asking me along. Just to sort of update, I'm actually the head of surgery at Lifehouse Cancer Centre, or Chris O'Brien Lifehouse Cancer Centre, which is sort of on the campus of Royal Prince Alfred. Unfortunately, little work gets done at RPA now, but you know, we've sort of established a nice unit. So look, from a head and neck point of view, yes, I've spent a bit of time in PNG, and I guess head and neck cancer is a massive issue in the South Pacific. So sure, we've heard about thyroid cancer, and we know about that, but a far bigger issue is oral cavity cancer. And when you look at Melanesia, because of the habit of betel nut chewing, you know, it's particularly in women, it's probably the most common cancer just after cervical cancer. And the incidence, they're world champions, you know, it far exceeds any other place in the world. You know, and you've got to remember there's 470 million people on this earth who chew betel nut, and the vast majority of these people are located in Melanesia. So mouth cancer, you know, tongue cancer, buccal cancer, cancer on the gingiva, on the hard palate, are exceedingly common. And the other problem is these people present incredibly late. You know, these people present, and I'm sure, Desmond, you know, these people present with not just regional metastatic disease, but often distant metastatic disease and essentially unresectable disease. So I think it is a real challenge. And in short answer to your question about, can you do this surgery? Absolutely. You know, I think surprisingly, you need a little resource to do head and neck surgery safely. You know, sure, if you're going to breach a viscus, if you're going to do laryngectomy, if you're going to do bone resection, you're going to need free flap capabilities, which is going to be way beyond what's happening in the South Pacific. But in terms of simple oral cavity resections and neck dissections, parotidectomy, and thyroidectomy to an extent, it's absolutely doable. You know, I mean, we do parotid neck dissections, which take us a couple of hours, and the people go home within 3 days, you know, and they, you know, done appropriately by skilled people. You actually need very limited resources. And I think, in short answer, the way to save people's lives is to control their regional disease. So, you know, that, or at least improve their quality of life and extend their life. You've got to, you know, control their regional disease. I think stepping right back, you know, it's about diagnosis of these cancers. So Deborah was talking about, you know, the pathology and the turnaround. You know, my question to Dr. Kemuel is, when they talk about doing thyroidectomy for thyroid cancer, what is the mode of diagnosis? How do they know these people have got cancer? And I think that reflects, you know, in biopsying oral lesions. That said, you know, for experienced doctors, you're going to be able to make a pretty good guess what's going on, particularly if you have neck disease. I think having cross-sectional imaging is absolutely paramount, not just paramount in terms of controlling the disease, but really importantly in keeping yourself out of trouble. You know, you could imagine that, you know, if without good cross-sectional imaging, you may embark on an operation that's going to do a patient significant harm, and you're going to have significant challenges getting the patient off the table. So I think cross-sectional imaging is going to be really, really important. And if that exists in the National Referral Hospital, that's going to help. Now, ultrasound capability, you know, you can bring that yourself. You know, we can do our own ultrasounds, and that does help. So look, in short answer, you know, controlling neck disease with neck dissections is absolutely doable. You know, yes, it is a technical operation, just like everything, you know, but you can learn. And I think it is something we could definitely embark on. I guess my next question is, particularly in the Solomons, you know, it seems to be a bit of a hotbed at the moment. And there seems to be some significant geopolitical issues, you know, and wrangling between superpowers. And my question is, you know, do we in this group of DAISI have any government support for this kind of soft diplomacy, you know, because that's what you're going to need. And B, do the Solomon Islands want it? You know, does their Prime Minister want involvement by Australia? Are they prepared to support? I mean, I've spent a long time, you know, teaching in PNG. over the years. And, you know, it's always been a real challenge in getting any traction and assistance. So, but anyway, in short answer, going there, doing a bit of a nectar section for a mouth cancer, doing a thyroidectomy and doing nectar sections for thyroidectomy, absolutely doable.
Well, thank you very much, Carsten, for, as always, a very comprehensive answer to the question. I think that we might be about to reach a pivotal moment, and Ian will talk about this a bit more, with some developments in terms of a CT scanner at National Referral Hospital, which may just give you that cross-sectional imaging that you say is paramount. In terms of government support and soft diplomacy, DAISI's policy has always been to be apolitical. You can't be completely apolitical, and certainly one aspect of DAISI is soft diplomacy. We have a memorandum of understanding with the Ministry of Health, with the surgeons mostly who are part of that Ministry of Health, and whether or not they want us is a good question. I think we have to keep asking that question, and we need to keep getting feedback from senior members of the surgical team, such as Mike Bowen Rooney, the CEO, the Director of Medical Services, and where, as part of our clinical governance, DAISI is working on feedback much more than what it did perhaps when it started out and went at things much like a bull at a gate. So I can't really answer that question, whether we're wanted at the moment. I think at the moment with COVID, we're probably a non-event where we're only doing telehealth educational sessions, and we're becoming more and more obsolete as time goes by. Hopefully, once we get back into things and start operating again and training up and working with, in collaboration, the local surgeons will be needed and wanted a bit more.
Look, I think there's no doubt that, you know, these are massive issues, and it's always, you know, the enemy of good is perfect. So I totally understand that you need to set very key and realistic targets, and it's often very important to keep very small targets. So I think simply teaching people how to do a nectar section, you know, is really doable. You know, just a question about, you know, governance and, you know, I mean, do you guys, you know, have any ticket from their local healthcare authorities that you're okay to go and do work there, or do you basically just get invited and just chop away?
Oh no, we're invited by the government, the Ministry of Health, and we've got a contractual arrangement with the government of the Solomon Islands and the Ministry of Health, which includes coverage for, you know, complications to the same extent that the local surgeons are covered for. So it's all quite official.
Yeah, perfect, because you don't want to get arrested at the border.
Yeah, yeah. So we're going to move on to Ian Hoskin-Richards. Ian, you are running the Solomon Foundation. You're the founder of this organisation, which to date has supported quite a number of cancer patients having specialist surgery in Australia, in Sydney mostly. We've had a number of DAISI members called upon, including Danny Cosman, who will be talking later about his own experience. What do you think are some of the advantages? Well, first of all, can you tell us about this program? Because I think we'd all like to know more about it, and some of the advantages and disadvantages of this model of healthcare delivery.
Yeah, absolutely. The Solomon Foundation, it's been going about 5 years now, and it was originally founded just to be the kind of, I suppose, the local support for all patients coming over to Australia for treatment. There's two different streams of patient that we get, and obviously COVID has interrupted a lot of what we do. But we used to have patients that were referred by the Overseas Referral Committee. They would be, I suppose, the charity cases where they would be, they would have some life-threatening condition, which means they're going to die in 3 to 6 months if we can't bring them over. but very often they can be quite easily and cheaply treated if they come over. I'm not talking about the cancers necessarily. That would be things like rheumatic heart disease, which is very, very prevalent over in the Solomon Islands, and it's quite easy and cheap to treat. So I think that the year before COVID, we had probably 30 overseas referrals, and probably over half of them were rheumatic heart disease. Some of them had cancers, and I suppose the challenge with the cancers is that, you know, they can be here for many months, and you don't know how much of your budget is going to chew up, and some of them chewed up a huge amount of a budget, particularly compared to something like a rheumatic heart patient. And then we also have government officials come over on a different stream. They're funded through the Prime Minister's office, and they have parliamentary entitlements. So if you're a foreign minister or a member of parliament, and you need treatment that can't be had in country, then you request overseas referral, and very often they get that. I think sometimes, as most of you probably realize, in the Solomon Islands, the higher up you are on the food chain, the easier it is to kind of jump a queue. So I think sometimes we get members of parliament come over that probably could be treated in country, but they prefer to be treated overseas. And this is a, from my perspective, and I've spoken with Gary about this too, is that, you know, that the cost is quite phenomenal of sending all these patients overseas. And if they could be treated in country, if they spent the money on the National Referral Hospital, we probably have much better facilities, and we could treat much more people with the same money. But, you know, this is very often a political decision. So, you know, it's something that I don't get involved with.
Yeah, and nor should DAISI. And I think parliamentary entitlements are out of, you know, the scope of DAISI to sort of comment on, and you can't avoid that sort of situation. What we're more concerned with is the average punter. And I guess Carsten's phrase, the enemy of good is perfect. We just can't afford, or the Solomon Islands probably can't afford to provide, you know, perfect surgery. What would be better is if we provided good surgery, homegrown. But, you know, we're still working on that model. Ian, can you tell us a little bit more about the CT project?
Yeah, we started the CT project way back in 2017, and the government provided 17 million Solomon dollars for the building. The building's now complete. The CT scanner now has also been fully funded, and we're just waiting for it to be installed. So, you know, that's going to be a huge benefit to the country. And I think they're talking about, you know, potentially 4,000 uses a year, something like that. So it's going to be in heavy demand.
Look, I think that's an amazing step forward for cancer surgery. And thank you very much, Ian, for being involved in that, and the work that the Solomon Foundation has contributed toward this eventuating. And I think it's going to make people like Professor Carsten Palm and other cancer specialists able to really come over to the Solomon Islands and contribute significantly and provide appropriate surgery where it's not going to cause harm. I mean,
absolutely. I mean, before, you know, when they didn't have one, the two options, one's to send them overseas for a CT scan, and often either to Brisbane or Fiji, which again is a very expensive exercise, or you just open them up and have a look around and see what you can see, and try and find out what's going on, you know, in that manner. Yeah. But yeah, CT scan is going to be fantastic.
All right, well, we're just about out of time. I might change tack a little bit. Thank you, everyone. It's a great wrap up for summary of the cancer services, the issues faced, and the possibilities moving forward. One of the difficulties for DAISI is attracting the right type of people, good quality surgeons who are prepared to give up their time, not just surgeons, medical oncologists, physicians. It's really quite a costly exercise for a surgeon to leave their practice for a week if they're going to go into COVID isolation 2 weeks. And it's not just the cost of them paying their own airfares, accommodation, but the loss of income while they're away. Danny, I thought I'd ask you, you've probably volunteered in the South Pacific more than anyone. As a busy, time-poor surgeon with a young family, you've got, I think, 4 kids under the age of 13. From your own experience, what factors attract surgeons in Australia to donate their time? And maybe you could provide us a checklist of what you think has attracted you and what would attract other surgeons.
Thanks, Gary.
Or specialists, not just surgeons.
Of course, yeah. So first of all, there are 3 kids. We're not counting the dog as a child yet. But look, I think from my point of view, what drove me initially to volunteer was, as most doctors, you go into this career with a desire to help people. And a situation like this, where you can go over to a country that's not as fortunate as where we're from, and provide teaching, but also a service of doing more complex procedures than would be able to be done otherwise, and therefore be able to prevent those patients from having to either forego treatment or go overseas. It's a very fulfilling thing to do for one's sense of self-purpose. Also, the enjoyment of problem solving, because you're often doing procedures without various pieces of equipment. You're often sitting down before an operation saying, well, what have I got and how am I going to work it out? And as you probably recall, Gary, that we did a lap APR with a hook diathermy and a homemade endo loop, and that sort of challenging yourself, as long as it's safe, is quite a rewarding thing to do. It's also good, from my perspective, to as a life lesson for my kids, to see that there's more to life than just doing what's beneficial for you. There's also a big reward for helping those who are less fortunate than yourself. But all of that was sort of the driving force for going the first time. But then it's what I found, having gone to volunteer not only in the Solomons but also in Kiribati, is it's an incredibly enjoyable time. It's an incredibly collegial time, and it's just a lot of fun to do. I really look forward to it. And I found that I take more out of it than I give. And I think that a lot of people have said that to me. You go, you recharge your batteries, you enjoy working in an environment where there's only so much you can do, and so that a lot of the pressures of our day-to-day life are taken off, and you leave having made a lot of friends, and leave having done a lot of good and taught a lot of people. And it's something I look forward to every year, going back either to Kiribati or going to the Solomons and providing this service. So initially I thought, well, here I am doing a wonderful thing for people, but it ends up being more beneficial for me than it is for the people I provide that service for. So I think that from that point of view, you're absolutely right, though. It is a big sacrifice for the family to have us away for that time. There's a lot of strain on the practice, but definitely it's worthwhile. And I don't know anyone who's volunteered who hasn't wanted to volunteer again.
Thanks, Danny, for that frank and honest answer to the question. I think you sort of hinted on the white saviour complex, although you're not really that white. And I think we all, if we answer that question honestly, there's a bit of heroism in going to the South Pacific and doing good and helping the less fortunate. And it's only after a few trips that you develop that collegiate enjoyment that comes out of these type of trips. And we really want to attract people like yourself who make it past the second, third and fourth visit, where the white saviour complex often doesn't sustain and get them through the difficulties they encounter. And I know what you mean about recharging batteries. And I think with COVID, there's a lot of DAISI volunteers out there running on flat at the moment. So hopefully soon we can all get a recharge. I've had a chat with Rooney today, and COVID vaccination rates are 20%. So they're still quite low in the Solomon Islands. They're in lockdown at the moment. There's an outbreak in Guadalcanal, in Malata, which probably is via Guadalcanal. And, quite a few of the medical staff are infected with COVID. So it's looking pretty dire at this stage. And he predicts probably not this year, but next year. But there are special government considerations, so we could perhaps seek out some trips if we're wanted, and that's where we need to make sure that we're wanted and not imposing ourselves on the Solomon Islands and creating more harm than good if we go over there and spread the COVID around if we're currently infected. So thank you, everyone. It's a great session, and I'm glad that we got the turn up that we did. This will be uploaded to YouTube as a resource and as a reference for future comparison, and hopefully in a year or two's time things will be a lot better in terms of cancer care delivery. Alrighty, till next time, we'll sign out now.
Thank you.
Thank you.
Thanks, Gary. Thanks.
Thank you.
Bye all.